So this session is looking in a bit more detail at, by looking at cause of death data. And what do the patterns tell us about, and does it help us to understand better some of the trends that we've seen in the all-cause mortality? So we think in the all-cause mortality, as we've seen in the earlier sessions, we've seen things like the high levels of inequality between different groups, and we've also seen increasing inequality over time, etc. So can the cause of death data help us to understand these sorts of issues a little bit better? So I'll talk about the motivation for looking at cause of death and the long-term goals. I'll remind you about the data and just tell you a little bit more about that, because it was just a brief mention early on. And then in terms of results, it's really just empirical work. So we haven't really done any modeling as such in this part of the talk. It's really just helping to understand the historical perspective. It's not at all thinking about how mortality, cause of death mortality might pan out in the future. And then also just a reminder that the last session and then this one, they're part of a package in terms of a sessional meeting paper on the 6th of January. All right, so when we're looking at cause of death data, so why are we looking at that? And the sorts of questions that we're thinking about are, what are the key drivers of all-cause mortality? Now, there are sort of two elements to that. So that is partly causes of death. So how do they contribute to all-cause mortality, and how have they driven the changes in all-cause mortality? But also what we're going to think about is a different type of driver. We're going to look at, or think about rather, the underlying lifestyle factors, so smoking, diet, exercise, etc. But coming back to causes of death, so can we, if we're say thinking about that earlier observation about growing inequality, can we point to specific causes of death that are the sole cause of this increasing inequality? And as a result of this, do we get any insights into mortality that's underpinning life insurance and pensions? Now, before we get to the data that we've used, there's a very useful resource that's become available in the last couple of years. So this is it's run by the Human Mortality Database Group in California and in Germany. So the HMD, the Human Mortality Database, looks at all-cause mortality, but in response to growing demand, they set up an equivalent sister database where they look at cause of death data. And so that's the website there. And at the present time, that covers 16 countries. However, it only covers national data at the national level. It doesn't look at different socioeconomic groups, which we're going to focus on today. But nevertheless, it's certainly in the United Kingdom, some other countries, you are able to get or work out or develop your own databases which involve causes of death by these different socioeconomic groups. So today's presentation will be looking at the English data, but our group has also looked at United States cause of death data by education level as a way of discriminating between socioeconomic groups. And then for Denmark, we're able to subdivide the population by, and at the level of the individual, not the LSOAs. In Denmark, we can use a measure of affluence to separate the population and then look at cause of death data. So from the data point of view, what we're thinking about is thinking about what are the most common or significant causes of death, and think about what are the trends over time. So that's the key thing. And what we're going to focus on here are the socioeconomic subpopulations, and then think about health inequalities, and then the maybe differential trends for subpopulations. Now, what are the drivers? So why do we see mortality improvements or indeed deteriorating mortality for some causes? So this is a group of three up at the top. So there are things like medical advances, or there may be public health initiatives or health spending by age. So some of these have been touched on in the discussion already this afternoon. And these are factors that are likely to, and this is maybe in the context of a stochastic mortality model that Torsten talked about earlier on. So in stochastic mortality models, you have age effects, period effects, and cohort effects. And these top three would be most likely to result in an impact on period effects, the kappa T's in these models. And then separately, we have the individual risk factors, which in my mind are more likely to result in cohort effects within the stochastic mortality models. So these are individual risk factors, and in particular, in my mind, I divide these up into two types. So there are what I would call controllable risk factors, although if you look at the Cancer UK website, they tend to refer them as preventable risk factors. So things that, if you take action, then you can reduce risks. But controllable factors are things like smoking, diet, exercise, alcohol, etc., etc. So these are all things where the individual has some control over, or a bit of a decision-making process at some time in their life. They decide to take up smoking, etc., etc. So they have some control over that. In some cases, not so much, but they are, in some level, controllable risk factors. And then other risk factors are not easily controllable. In particular, the ones that are definitely not controllable are genetic factors, and genetic factors it could be family history, that sort of thing in terms of the genetics, but it could also be racial. So there are certain diseases where, in causes of death, where there are certain ethnic groups that have higher rates of mortality from a particular disease compared to another one. And of course, that's not controllable. It's just a matter of fact in terms of the differences between different groups. Affluence and education, there's maybe a little bit of a degree of control over there, but it's perhaps more early in life where by whatever mechanisms you can sort of improve your future prospects by working hard at your education, etc. But by a certain age that you could regard these as more or less locked down. And then also not easily controllable, except in the very earliest years of life, are character and personality traits. And so, for example, the character trait that is most closely correlated with mortality is called conscientiousness. And the reason why there's a link with mortality is that conscientious people are more likely to go to the doctor earlier if they start to develop some symptoms of a serious disease. But then after diagnosis, they're also more likely to follow the prescription and the medical advice that's given to them. So there's sort of various reasons why you can understand why conscientiousness as a character trait might affect an individual's longevity. But again, it's something that's really locked down early in life. And then perhaps there's a sort of different, sort of not easily controllable thing because it's in the past, are things like prior health events. So something like a heart attack where it's known that there are sort of various subsequent causes of death which are much more likely even if you've fully recovered, that you're, for example, more likely to get Alzheimer's disease, or that's how it's thought, more likely to get Alzheimer's disease if you have suffered a prior cardiac event. Now, in terms of potential measures of socioeconomic status, so there's lots of different ones. We've talked about some of them today, so low income, etc., etc. And in terms of deprivation, there's also education, there's also affluence, and we have that data for different countries. And the point is that, as we've talked about before, that in terms of the all-cause mortality, we know that if an individual is in a more deprived area, then they have higher mortality. But the reason they have higher mortality is largely because of things like they are more likely to smoke, or a greater proportion of people in a deprived area, a greater proportion are likely to smoke, a greater proportion will have a poor diet, etc., etc. And that is what leads to higher mortality. It's these controllable risk factors that are, to a large extent, responsible. Now, in terms of the analysis and the empirical results coming up, we've got a long list of causes of death that we've been looking at. So in this presentation, there are 34 different causes of death, covering all of the different causes. Now, why have we chosen a list of as many as 34 instead of what often you see is that there might be just one group for cancers and another group for cardiovascular, so it's all just maybe 6 or 7 different bigger cause of death groups. So the reason why we've gone for this much longer list is that, for example, within the cancers that have all been highlighted in red, some of these cancers are very closely linked to significant risk factors. So lung cancer, clearly linked to smoking, and there's a very big difference in mortality rates if you do or do not smoke. And then there are other cancers, say such as breast cancer, where there are no known significant risk factors for breast cancer. So when we analyze the data, we really want to be able to differentiate between these different causes of death, because that will help us to get a better understanding of things like the underlying lifestyle factors. Whereas if we looked at all cancers just under one group, then we would find it much more difficult to think about these underlying controllable risk factors. So for the data that we've got these 34 cause of death groups. We've got, because of what I mentioned earlier, was that for causes of death, they're considered, that information is considered to be more sensitive to the surviving family members, invasive, that sort of thing. So we cannot get data down to the level of LSOAs. And also we have to use 5-year age groups rather than single ages. So all of this was, to some extent, the result of some negotiations on my part with the ONS in terms of a user-requested data set, and there was some toing and froing in terms of how much detail could I get, so that this was what we settled on. But it also included, in my mind, I definitely wanted to have individual years rather than groups of years, because I really do want to look at the year-to-year fluctuations, maybe for some diseases more than others. So we've then got subdivisions, and so instead of the LSOA level, we've got subdivisions by income deprivation, so that's over all ages, income deprivation. So that's into 10 deciles, and then we've got 9 regions. So there's 90 different groups, if you want to call it that, and rather than the 33,000 that we had for the LSOAs. Now, just as a starting point, before we sort of get into some of the graphs, so you can also then, starting from that list of 34, so what are the major killers? And of course, there's a different table always for sort of males and females, and then there's different tables for different age groups. So this is just a snapshot, and it's comparing the most deprived with the least deprived groups. So in between, there's a whole lot of other deciles, and this is not looking at the regional differences. So what are the top 10? And the key thing is that the two lists for the top 10 for the most deprived and the least deprived, there are some similarities, but there are also some quite big differences. And what I've done here is to highlight in blue prostate cancer for this group of males. Now, the reason I've highlighted this is that prostate cancer has no controllable risk factors, and therefore the death rates here are about the same as the death rates for the least deprived group. So that's saying that all of these 9 on the left-hand side, all of these 9 have higher mortality rates than the 5th ranked cause of death on the right-hand side. So it sort of highlights the differences there. And then the causes of death that appear on the left-hand side, but not above prostate cancer on the right, these are, if I can pick ones out, so cerebrovascular, for example, or esophageal and stomach cancer. So these have leapfrogged prostate cancer, and the reason is that these are causes of death that have significant controllable risk factors. And so there's, in terms of and it's a reflection of the fact that in the most deprived group, there's a bigger proportion of people are following these unhealthy lifestyles in terms of controllable risks. And then, again, a similar table for the females, and the top cause of death that has no controllable risk factors is breast cancer. And again, the differences between the left and the right in terms of leapfrogging that particular cause of death. Now, some of the charts that I'm going to put up are showing the age standardized mortality rate. That's the basic calculation of the ASMR. So it's looking at the death rate at a particular age. And in this formula, I've just suppressed all of the other variables, such as region and year and things like that. So we're just focusing on a table of MXs. And then rather than use the actual exposures, the standardization uses a standard set of exposures. So and I've used the European standard mortality. And the key point about that is it makes it possible for you to compare different areas that maybe have different age profiles. So one population might be relatively old, another population might be relatively young. And if you just looked at the headline mortality rates, then the younger group would have lower mortality. But the age standardization removes that difference. So that's the basic definition. And then what we're going to use are a number of variants. So first of all, we've got the national level ASMR. We can then calculate the ASMR for a different ASMR for each of the 10 deprivation deciles. We can calculate an ASMR for each region. And then this links to a plot that I put up previously. It's what I call the age and deprivation standardized mortality rate. And the point here is, as I said before, is that some regions have a much higher proportion of more deprived people. Other regions have a lot less deprivation. And so those differences will cause a difference between one region and another region, simply because of these differences in the socioeconomic mix. So what the ADSMR aims to achieve is to remove the impact of these differences in terms of the deprivation profile. And here it's using the income deprivation. So just to highlight that point in terms of the differences between regions. So region 1 is the northeast, and in the northeast of England, each row adds up to 100%, and the numbers are the percentage of that region. So 20% is of that northeast, 20% of the LSOAs, 20% are in the most deprived decile, and 15% of the LSOAs are in the national level second decile. So that's heavily weighted towards the left for the northeast and also the northwest. And then down at the bottom, the region 8, which is the southeast of England, the weight is the other way around. So there's a high proportion of the LSOAs are in the least deprived deciles. So that's just emphasizing why do we want to try to adjust the ASMR to remove this sort of effect. So sort of in a nutshell, for the ADSMR, the Age and Deprivation Standardized Mortality Rate, what we're doing is that instead of using, for the regional mortality, the basic regional mortality just uses these weights. But when we do the age and deprivation standardization, we measure the ASMR, or the mortality, for each one of these 90 cells, and then we give a weight of 10% to each one of these 10 deciles, rather than 3, 5, 7, 9. And so that tries, in a simplistic way, to remove the impact of the different deprivation mixes. So in terms of these variants, so this is just the formulas for that. So we've got these different measures of mortality. So national level, mortality rates by income deprivation or by region. And then there are these 90 different combinations of region and income deprivation. And then so these are the basic formulas for these different variants. I won't dwell on those. But then when it comes to the age and deprivation standardized mortality, what we're doing is we're calculating the ASMR by region and by income deprivation, so that the region is fixed, but then we take 1/10 of each of those to give us the ADSMR. And so, as I say, hopefully that removes the impact of the deprivation mix. So this is a chart that's somewhat similar to what we saw in the last session. But on the left, we've got the income deprivation deciles. So no regions here. In the middle, we've got the ASMR by region without the deprivation standardization. And then on the right-hand side, we've adjusted the regional mortality to take out the impact of deprivation differences. So the starting point is just to note that the inequalities by income deprivation are very much bigger than the regional differences. So that's comparing this one with the other two. But nevertheless, there are, after adjusting for deprivation, that there are still big differences. So again, as we talked about before, we really want to think about what perhaps are the reasons for this London effect. Is it improvements in healthcare or public health initiatives? Is it perhaps due to GDP? Because the GDP in London has certainly grown at a faster rate than other regions. Or is it the sort of various forms of gentrification? So are educational levels generally rising in London? We also see differing trends since 2011. So again, there are implications for mortality projections that we talked about in Torsten's presentation. And then if we look at females, a very similar picture. If anything, the inequality gap is widening more for females than for males, but still, again, a London effect. And then before we get to the 34 causes of death, I thought it was interesting just to show how for these bigger groupings of causes of death, which cause of death groups are the biggest. So this is for females in the 65 to 69 group. And the black section at the bottom, that's the circulatory and cardiovascular diseases. The red is the cancers, and then it's respiratory diseases in green. Blue is the sort of other, so that's just not under one of the other main headings. You've then got the sort of mental and nervous system, so that's Alzheimer's, and then things like vascular dementia, and then external causes and infectious diseases. So they're all relatively small for this particular age group, 65 to 69. But the two charts here are for the most deprived group and the least deprived group. And of course, again, it just emphasizes how big the difference is between these different sections of society. But also it's about the sort of relative sizes of the different causes of death. So the cardiovascular diseases are very much smaller. The difference between the cancer rates, there is a difference, but it's not, in percentage terms, it's not quite such a big difference. And that's maybe linked to the fact that some of the bigger causes of death, particularly females, it's the breast cancer there, for example, so that's doesn't have any significant controllable risk factors. So that comes out in the all-cancer mortality in terms of not such a big gap. You do see a big gap with the respiratory diseases, which is going to be linked to smoking, so we'll talk about that more later. And then lastly, you can see that the orange bar is gradually getting wider, and that's over time that Alzheimer's disease is becoming a more significant cause of death. And there's a similar picture for males. So for that higher level summary, so the cardiovascular diseases, we've seen very big declines, as you all know. But of course, that then means that in the future, there's maybe rather less room for contributions to a decline in the all-cause mortality rates. I mean, it may well be that in percentage terms, the cardiovascular diseases might continue to improve at the same rate. But if it's already getting close to zero, then there's not much, it's not going to make much of a contribution to the all-cause mortality compared to the potential for improvements in terms of cancer treatments. And then respiratory diseases is where we see the biggest inequalities. So we'll have a few charts now looking at particular causes of death. And so before we look at the actual cause of death itself, just to help you understand the charts. So the calendar year on the x-axis, and then on the y-axis, it's the age and, well, there are two versions. There's the deprivation deciles on the left, and then the age and deprivation standardized mortality rate by region on the right. It's a log scale, and it's from top to bottom, it's a factor of 8. So the actual numbers will change, but the scale is going to remain the same. It's at 8 times for almost all of them, top to bottom. And then also to help, there are these horizontal dotted lines, which are a square root of 2 apart. So in other words, going from here, jumping up 2, that's a factor of 2 from there to there. So that just helps you to think about the trend and also the levels of inequality in these charts. So 9 regions, 10 deciles, and of course what you can see here is for lung cancer, in this case, for males, you see very big differences between the most deprived and the least deprived. It's about a factor of, what was it, 2.5 times, I guess, there, and widening to about 3 times on the right. And then when we look at the by region, so we've removed the effect of the different deprivation mix. So if there were no regional differences beyond deprivation, then all of these regions would be compressed down to about lying along the same sort of slope. But that's not what we see here. We do still see quite big differences between the regions. And so that is an indication that even after you've taken account of the deprivation differences, that in general, people who live in these regions, so the black, red, and green, so that's the northeast, northwest, and Yorkshire and the Humber, so they are just generally, across all social groups, these people in these regions are more likely to be smokers than not. And the reason I can say that is because it's lung cancer, and the controllable risk factor is smoking. So you are 20 or 30 times more likely to die from lung cancer if you're a smoker compared to not. So, and to the extent that the difference here is about 40%, so that's an indication that across the board that there are around very approximately 40% more smokers in these 3 regions at the top compared to other regions. And we can also see a bit of a London effect. So the thick black line is London, and that seems to start off in the middle, but then it declines at a faster rate. Now that might be public health initiatives, or it could be gentrification, etc. So it's, again, we don't have the data yet to really decide what the reasons are for the London trend. If you look at females, or, well, I should say with males, you could see that there was a gradual downwards trend. So if there's a downwards trend in lung cancer, the key thing also to remember here is that there haven't really been any significant medical advances with the treatment of lung cancer, and certainly no cures. There's maybe some advances that have slowed things down a little bit, but there's still some way to go. So the fact that there's for males, the fact that there's a downwards trend here, but to some extent, that is an indication that smoking prevalence, so the number of people who smoke, that has been going down in the male population. And that contrasts with the female population, where there's a slight upwards trend, particularly for the more deprived group, fairly flat for the least deprived. So that again, that's an indication that there have been slightly rising numbers of smokers in the female population, but starting from a lower starting point compared to males, but numbers have been increasing rather than going down. And then, again, similar differences in terms of the by region, and the ones that are at the top are the same three that were at the top in the male. So again, it's sort of an indication that it's about fashion in terms of whether it's fashionable to smoke or not in these different areas, rather than just being randomly different for males and females. We can then look at respiratory diseases, and in particular, this includes chronic obstructive pulmonary disease, or COPD, and that as a significant element of that. And this is a cause of death that is, again, has smoking as the controllable risk factor. And so the pattern here is very similar in terms of the levels of inequality and also the widening spread. Again, that's very similar to the chart that we had for lung cancer. By region, it's similar, but maybe not quite as spread out as for the lung cancer. So there's, again, maybe some differences there that we're still to explore just a little bit further. And then, again, similar for the females' respiratory diseases, it's a similar sort of picture when you compare lung cancer with respiratory. We can move next to ischemic heart disease, and the difference here compared to lung cancer is that there are now multiple controllable risk factors, so diet, exercise, and things like that. You can also see that compared to lung cancer, there's this steep downwards trend. So amongst all causes of death, this is one of the ones that has the steepest trend down the way. But again, as you might expect, because of these controllable risk factors, then there are big inequalities between the different groups, and these inequalities are again widening. And also, again, significant differences between the regions. The next disease to look at is diabetes. So I'm not going to go through all 34, by the way. Don't worry about that. But, the data here are a bit more noisy because the numbers of deaths are smaller. But again, we see even bigger differences, I would say, between the deprivation deciles, so that there's an even bigger source of inequality. And of course, diabetes, there's no smoking factor here. It's other factors, and in particular, diet and exercise, for example. And again, significant differences by region. And then this time, London doesn't stand out as having bigger improvements over time, and it's stayed pretty much static compared to its position against other regions. So coming back to these controllable risk factors, so if there are particular risk factors, so smoking, diet, etc., some of them are controllable, and then there are other risk factors that are not controllable. So all of these do have, whether they are controllable or not, they do have an impact on death rates. And in particular, we've so far looked at the controllable risk factors, and they can have a big impact on some causes of death. So smoking has a big impact on lung cancer and also respiratory diseases. Several risk factors feed into ischemic heart disease. And the key point is that when you know there is this significant risk factor, then you always see significant mortality inequality. So all of these other charts that I've got, if I know there is a smoking factor or a diet risk factor, you will see big inequalities between the deciles and also smaller but significant differences between regions. But then there are other causes of death where there are no known significant controllable risk factors. So prostate cancer and breast cancer are examples of that. So what do their charts look like? Now, before I show that, we can also just observe that the more the impact of a controllable risk factor, as it increases, we see increasing inequality in terms of deprivation in region, and by region even after you've adjusted for differences in income deprivation. So there are these variations between regions that go beyond the deprivation effects, but what it seems to be is that the ordering, once you've done this deprivation standardization, the rankings of the regions, it's not always the same for different causes of death. So that's kind of an indication that even though in the north they maybe have more smoking compared with the south, there are other controllable risk factors that are not so strong in the north compared to the south. So there's a bit of a randomization in terms of what the order of the regions are after deprivation standardization. Now, so here's a chart for breast cancer, and this is what I think of as a sort of success story in the sense that, first of all, on the left, by income deprivation, there's a certain amount of noise in the data, but you look at that, there are 10 lines there, but you'd be hard-pressed to say that one line was generally higher than another line. So it's really saying that death rates from breast cancer do not seem to be at all linked to deprivation. And then similarly, when you look at the regions, again, there's no significant differences at the regional level in terms of breast cancer. And then also part of the success is that you can see that there's a steady decline in the death rates from breast cancer. So that will be a combination of earlier diagnosis and improving treatments. For prostate cancer, it's nearly similar. So certainly by income deprivation, again, you'd be hard-pressed to see any differences. So this is over the whole 16-year period. On the right-hand side, however, by region, London does seem to be doing better. And again, we'll see one or two other examples of that. And there might be a variety of perhaps innocent reasons, but it could also be that London is doing a better job of treating its population for this particular disease. And it's even more so for ovarian cancer, where again, smaller numbers of deaths, so it's even more noisy compared to breast cancer, for example. So certainly, purely by income deprivation, there are no significant differences. But when you look at the regional mortality rates, there are very clear, I mean, they're not huge, but there are very significant differences between the different regions. So again, even more so than prostate cancer, there's a question in my mind in terms of why is that? Why are these regional differences when there are no differences in the deprivation deciles on the left? Here's Alzheimer's disease. It's a favorite topic of conversation amongst actuaries in terms of where are things getting worse. In this case, it's similar in the sense that by income deprivation, there are not big differences, except maybe for the decile 10, the sort of pink line. So I'll comment on the increase in the next slide. But you see very big differences. I mean, this is much bigger than the last slide very big differences at the regional level. However, and I think here there may be a combination of effects, but one of the reasons for these differences could be some sort of health migration, and in particular with London being at the bottom, I suspect it's quite likely, and that the care home data that I mentioned in the previous session would perhaps back that up, that a lot fewer people are in, as a proportion of the retired population, a much smaller proportion of the population is in a care home in London compared to other regions. And that would suggest that when people get into very poor health, they're perhaps more likely to move out of London to a care home where costs are potentially cheaper than staying in the city. And then, still sticking with Alzheimer's disease, we have this deterioration, and that could be, again, a variety of reasons, but one reason might be a gradual shift towards the way that disease, whether that gets reported as the cause of death or whether you die from something else. And that's one possibility. The other possibility is about the frailty of people that are reaching old age. So instead of death rates being sort of independent of each other, so if you improve one thing, mortality rate of another doesn't get affected. But for example, the frailty issue is that there is thought to be a link between earlier cardiovascular events. So if you've had a heart attack or something like that, then you are perhaps more likely to get Alzheimer's disease later in life. Now, what we've seen is that there have been big decreases in mortality rates from heart disease. Now, and part of that decrease will be people that have had a heart attack, but they've survived rather than having died. So there's this extra group of people that are on bigger proportions that are reaching older age. And so that's maybe a factor there, although I would be surprised if that frailty argument had caused such a big increase. This is the other mental illnesses and dementia. So as a group, there's one group of diseases that are related to younger age mortality, and then the higher ages, it's vascular dementia that is the key thing here. Sorry, that's not by age, this is by year, sorry. So there's a certain amount of variation over the first few years by the income deprivation deciles. So that's because these diseases do have links to controllable risk factors. We see a jump, and that jump is because of a change in the classification of causes of death. So it's not that more people are suddenly dying from this. There is a shift in terms of how people were reported, in particular from cerebrovascular diseases or strokes. A lot of those are now being classified as vascular dementia. And there's a link there in terms of the symptoms of vascular dementia. And again, significant differences by region. And then last 2 or 3 slides are looking at the deaths of despair, which have hit the headlines in North America more, and people are starting to look at them here. So things like alcohol-related liver disease, this is much more so. So the deaths of despair have even bigger amounts of inequality, and in fact, instead of it being a factor of 8, it's now maybe a factor of 16 or even 32 on this scale or the next one. So very big levels of inequality by alcohol, but no particular time trend. So this is just an age-old problem, and it's people that are in the more deprived area, low self-esteem, so they drink more. And then still some regional differences. Accidental poisonings, again, and this is the opioid epidemic, or the overdoses there. And so we've seen very significant increases as well as very significant levels of inequality. But it's this steep rise in deaths from accidental poisonings that's really causing a lot of concern. However, it's tending to, I don't think I have a slide here on it, but it's tending to affect the people more in their middle ages rather than high ages, and the total numbers of deaths are also not huge. So although it sort of looks very dramatic, in terms of the contribution to all-cause mortality, it's not that huge. I mean, it's noticeable, but it's not the major cause of any slowdown, for example. So summarizing some other things that I've drawn out of the data. So what causes of death have been causing growing inequality? So there's a number of diseases there. So we've seen it in a lot of these charts: heart disease, diabetes, and a little bit of a widening with lung cancer and respiratory. And the key point is that all of these are increasing in terms of inequality. They're all increasing because of these controllable risk factors. So these are really the source of inequalities rather than anything else. So it's really telling me that there is a widening gap. So if you're looking at the deciles, the most deprived and least deprived deciles, there's a growing gap in terms of differences in smoking or differences in diet. So even if there's an improving trend in the most deprived group, even more people are giving up smoking at a faster rate in the least deprived group, that sort of thing. But it could be going in the other direction. So in terms of diet, poor diet, growing numbers perhaps in the most deprived, whereas in the least deprived group, people might be growing, might be more of a trend towards improving diet, that sort of thing. And if we look at the slowdown since 2011, again, it's a bit more difficult to really pinpoint things here, but it tends to be what I think is it's partly heart diseases, although I forgot to highlight this actually, but for heart disease, ischemic heart disease, the least deprived group had no slowdown at all since 2011, whereas the more deprived groups did have a slowdown. So that was and that was even more marked for the females. So that I forgot to mention that. So the slowdown is due to heart disease is some deprivation groups more than others. Dementia and Alzheimer's, definitely that's worsening and causing a slowdown. Possibly respiratory diseases and possibly diabetes. So there's not a long list of causes of death that seem to be impacting on the all-cause mortality slowdown. So briefly, death rates by age. So instead of through time, we're now looking at age. And you can see how, as we saw earlier, much bigger inequalities at young ages, small inequalities at high ages. So that's cause of death 22, which is the ischemic heart disease. And then the reason I put here road and other accidents is that when I was looking at all of these plots, I've got plots of this type for all of the causes of death. And what was quite striking was that a lot of causes of death had a sort of Gompertz type of shape. So this is on a log scale, the death rate. And you can't really see it, but there's a sort of gray dashed line, and the gradient of that gray dashed line is 0.1. So that's the Gompertz model with 0.1 as the rate of increase of the mortality curve. And then the other dashed line is 0.2. So there's what I've called group 1, and these are causes of death where you see very similar pictures, and they're all starting off at different levels, but they're all growing at this roughly 0.1 rate. And that includes here, at the higher ages, road and other accidents. And the sort of interpretation of that is, and you should always avoid this, but the interpretation is just the increasing frailty in old age. It also causes you to have accidents in the home, for example, falls and things like that. So there's a group of diseases that are rather like that. You then have a different group that I call, this is looking at smoking-related diseases. And so lung cancer is one that sort of flattens off a bit, but with high levels of inequality by the deciles. And then respiratory diseases, it's a sort of relatively steep set of curves. So somehow there's a bit more in terms of understanding, they both have the same driver, smoking, but respiratory diseases seem to take over at the higher ages. And so there's perhaps something here about either the frailty of varying levels of frailty in terms of how susceptible people are to lung cancer compared to respiratory, or the alternative is that with respiratory diseases generally, that the relative risks might be age-dependent and that they are bigger in older age for respiratory diseases. So a number of different reasons perhaps for that. We then have this group 2, so the group 1 was the Gompertz 0.1. Group 2 are mostly cancers, and these are all flatter. So they're either steep and then level off, as with lung cancer, or there's this breast cancer, which is a much lower slope than the 0.1 curve. So again, I'm not a medic, I don't understand biology, but statistically there's something different about cancers compared to the sort of general old age deterioration. And then there's another group of diseases which are much steeper, and this is dementia and Alzheimer's disease. And this is quite alarming, I think, because it's around about 0.2, and it's at that level, it's actually crossing over other causes of death in terms of becoming the major cause of death around about the age of 90. Now, and it's only, the only ones that come into this group are the diseases that are deterioration of the brain. There's no other diseases have that level of steepness in the high ages. Now, the good news, if it is such, if there is, you could call it such, is that from looking at US data, it does seem to flatten off a little bit above 90, so it doesn't carry on at that same high rate. But again, there's something about the deterioration of the brain compared to deterioration of the rest of the body and also cancers. And then group 4 is the diseases that are more linked to younger ages, so things like the deaths of despair and also some of the mental illnesses that are not dementias but affect younger ages. And so they tend to be rather flatter and sometimes decreasing with age. Right, so just to summarize, so causes of death, so the key takeaway here is about controllable risk factors. So because it's the controllable risk factors that result in mortality inequality. And we see statistically significant levels of inequality for most of the big causes of death. Regional differences remain after you've adjusted for deprivation differences. On the other hand, if there are no controllable risk factors, little or no inequality, and then mortality inequalities, we've seen them widening, and that's the link there is to a widening gap in these underlying controllable risk factors. And then the slowdown since 2011 and the link to ischemic heart disease, where there's, for heart disease, no slowdown in the least deprived group. So that was something that I forgot to point out with when we had that chart up. But that was an interesting finding about that particular group. And then we had a separate mention of the other factors for a slowdown. So I think that's it for that session. So thank you. So we've got a few minutes for questions or general discussion, and if you want to wait for the microphone, I'm not sure where. Yep.
Really interesting talk again, thank you.
Thank you.
Do those charts lead you to reach a conclusion that the widening that we've seen in Torsten's talk and others today is going to stop at some point? I was just sort of thinking the controllable stuff, the opportunity to make improvements on the controllable stuff for the higher socioeconomic groups looked to be dwindling because there was not much cardiovascular left to improve, etc. So have you got a sort of summary view of how long it's going to last? Right, well, great question.
You'll have noticed really that I've almost completely avoided talking about the future. So because I'm to some extent I'm not totally sure, although the key thing that you touch on is the fact that there are these controllable risk factors that are, and they're perhaps the driver for these differences between groups, and whether it's a widening gap, even wider in the future, or whether it narrows. And of course, so this is where you definitely get into the debate of expert opinion, if you want to call it that, or pure sticking your finger in the air, or whatever. Because I think statistical analysis, or in terms of modelling, using the past to model the future, I think that's you're perhaps on rather dodgy ground there in terms of the robustness of the statistics, as well as other factors that, again, I briefly touched on, that the way that causes of death get reported, that maybe changes a bit over time, and it's not so difficult to filter that out. I certainly think there's a lot more to be done here in terms of really nailing down, because I've talked about, well, this is linked to smoking, but it's not so easy to actually say, well, how many people are smoking in that group versus that group. So you need some other data sets, so smoking prevalence, and we're looking at US smoking prevalence data with that data, and they have enough detail there to be able to link what we see in the lung cancer and respiratory cancer with diseases. We can link that to the patterns that we see in smoking prevalence. So the link is definitely there if you can get the data. For the UK, smoking data is a bit patchy, and the way that they measure it varies from year to year a little bit, so it's not quite so easy. But and then there are other controllable risk factors, such as diet, where it's maybe more of a sliding scale, because to some extent, you either smoke or you don't. I mean, it's more than that, but it's numbers of cigarettes. But whereas with diet or obesity and things like that, it's much more, you can have a slightly bad diet, or you can have a massively bad diet, things of that sort, and that will have a bigger effect. So trying to sort of filter these things out is perhaps quite a challenge. But I think what we would maybe think about here is you could maybe do some more speculative modelling, just sort of try out some scenarios. So you would perhaps have to try to model what the lifestyle behaviours are in the underlying population. I mean, just as an experiment, just to see what might happen. But it's very speculative, and I wouldn't rely on that as some sort of accurate forecast of the future. But it's definitely a fascinating topic for further work. Sorry, Chris.
Firstly, an observational hypothesis, and that's those fascinating regional heat maps you were showing, which changed with age. It struck me that this almost represented the history of 20th century England, and having worked as a medic in the Northwest in the 1980s, where there were very high prevalences of what we referred to as the Salford lung, because essentially if you were born between 1930 and 1960, you were smoked from birth, regardless of whether you smoked.
Yes.
And it was interesting how that 70-year-old age group was clustered around the northwest.
Right.
And that was perhaps borne out by some of the where you could see the cohort moving.
Mm-hmm,
I think you also showed. The real question is, are you going to publish this? This will be fantastically interesting to the NHS, Public Health England. I'm sure you'll publish it in the actuarial. But do you have any plans to get this into the medical journals?
Well, so the starting point is that we do have the sessional meeting coming up in January, but we then will be sort of subdividing that bit of work to sort of target some other journals. So we're certainly thinking about medical or other journals for particular bits of that work. So I might actually come and talk to you in terms of what might be the best places. And equally, I think also with the help of the policy team within the IFOA, that we're going to try, just separate from the journal publication route, just try to reach out to the medical profession and the public health people, because there are some things that they might spot that we haven't yet, or etc. Yeah. Thank you. Alan, did you hear?
Just in terms of the London effects and regional effects after stripping out income deprivation, I'm wondering, is income deprivation capturing what it should? I'm not sure exactly how it's measured, but in a city like London where salaries are generally higher, but the cost of housing is probably a bigger proportion of many people's income. I'm wondering to what extent income deprivation needs to be more sophisticated.
Yes. So when we started off requesting this data from the ONS, we sort of relatively early on, so we had been already working on income deprivation as a way of subdividing the population. And then, so that's fed into this last presentation on cause of death. Now, what we need to do next is to sort of go back with a different measure of mortality deprivation, if you want to call it that, and get the population subdivided. And that will possibly narrow the gap between the regions. So, because we saw that at the all-cause level, that if you used income deprivation and then did the regional standardization, you narrow the gap from there to there, and then if you use the alternative sort of measure where you're focusing on getting mortality, then you can reduce that gap to this at the all-cause level. And it may well be that for the cause of death that we would hopefully see a similar sort of thing. Okay, well, I think everybody's exhausted. I am. So, first of all, thank you very much for all of you that are still here. There's only one or two that have left, but thank you very much for coming along today. And if you want to find out more, then do contact me after the event, or we have drinks in the council chamber immediately after. If you want to find out more about the ARC, you can again talk to me or also Fiona Darwin up at the back. And so I think that's... Oh, yes, in the next day or so, you will receive a feedback questionnaire. So please do take the time to fill that in, because the comments that you give us are extremely useful in terms of thinking about future events and also the different directions of research that we might be taking. So thank you very much.